Good day to our future dentists. Today, I hope to share a bit about renal physiology, exploring the wonders of kidney function and dysfunction. Now, why would renal physiology be important for us dentists? Well, first of all, chronic kidney disease, or CKD in the Philippines, happens to a lot of patients. Currently, around 7 million of them have chronic kidney disease, and of course, these patients have teeth, so we'll be working together with you in order to take care of our patients. Now, for the connection of oral health and kidney disease, periodontal disease happens higher in CKD patients. They have a higher risk, so we need to work together to encourage them to keep their mouth health. Also, if we recall, the kidney is responsible for the fluid balance in our body. So if there's no fluid, there's impaired salivary function. And this can lead to xerostomia or other diseases in the mouth like dental caries and oral infections. Other than this, some of our patients get medications for their teeth, but many medications prescribed to kidney patients can have effects on their mouth. And other than that, the dentist giving the medicines such as the antibiotics or other painkillers would need to know that the kidney is helpful in excreting these drugs. And if they're not working well, the excess medications can affect our patients. So these are the few reasons why we think kidney physiology would be important for us. Other than this, kidney disease is among the leading causes of death, and I hope that today, whatever we learn can also be helpful to our families and friends in the future should they get kidney disease. So at the end of the lecture, I hope that we'll be able to define the key components of the renal system and explain the function of the kidneys in maintaining homeostasis. I hope to focus on two concepts, the glomerular filtration rate and the tubular reabsorption. And also, we hope to understand the regulation of blood pressure by the kidney system and discuss the relevance of renal physiology and dental practice, which we already touched upon. So this is the source of our lecture. We first begin by the kidney anatomy. So the kidney are two bean-shaped organs found at the back of the body, and they are responsible for producing urine. So the kidneys are attached to the body by three structures. We have the renal artery, which is the blood vessel, causing the approach of the blood into the kidney. When the blood then approaches the kidney filters it, and then the things that the body needs will exit through the blood in the renal vein. This blood will go back into the circulation and affect the different parts of the body. The solutes and the fluid that is not needed anymore will exit through the urine via the ureter so that it can leave our body. Now, if you magnify our kidney, it looks something like this. We would have what we call our renal cortex, which is in the orange. The fruit is like the balat. And then we have our medulla, which is like the laman, which is composed of different pyramids or finger-like projections, which will collect the urine from the functional unit of the kidney, which we call the nephron. Now, once the medulla or the pyramids or finger-like projections collect the urine, they will be pulled together in what we call the renal papilla, which are like the bigger fingers that collect the urine, then pulled together in the renal pelvis, which eventually becomes the ureter or the tube from the kidney to the bladder. This will have the increased waste products which can exit the body. Now, if we focus on this part, the functional unit of the kidney, which we call the nephron, and enlarge it, it will look something like this. So we studied the renal vasculature or the blood vessels, and we would have the parts. We'll discuss it later. So going into the nephron, we would have what you call the glomerulus and then the tubules. The glomerulus is the filter which produces the urine, and the tubule is this long snake-like part which concentrates, dilutes, and finally refines the urine before it exits. Then we have our blood vessels, which we'll be discussing later on. But in essence, what I'd like for us to focus on is this is the functional unit of the kidney, which we call the nephron. Now, the blood supply of the kidney amounts to about 20%. So even if it's very small, it gets a lot of blood. The amount of blood going into the kidney would be around 180 ml per minute. And this is the blood vessels that go into a kidney. If we trace the blood vasculature, we had the blood entering the renal artery, then eventually going into what we call the segmental arteries. Then if it goes in between your renal medullary pyramids or the fingers, you would have what we call the interlobar arteries. Then here we have what we call the interlobar arteries. Then we have the interlobular arteries, the small ones. And then you would have the arteries here in the arc, which we call the arcuate arteries. The veins also follow the same path, except it goes from the smaller to the bigger blood vessels. Now, once it goes into the arcuate artery, it then becomes smaller and goes into their afferent arteriole or the approaching arteriole into our filtering part of the nephron, which we call the glomerulus. Then, once the filtration happens, you have our efferent arteriole or the exiting arteriole. The important thing to remember about the arterioles are they are very thin, and then eventually when these exit and they change into what we call the capillaries or the single cell blood vessels that are beside the tubules, we have what we call the peritubular capillaries. Now the important thing here is that here in the glomerular tuft, or what we have the blood vessels that are spinning around inside the glomerulus, what happens is that there is filtering that happens. The blood is screened out, and then eventually those water and solids that we need exit through the urine. However, here in the tubular area, you have the close connection of the peritubular or the beside the tubule capillaries and the tubules themselves. The capillaries, as we recall, are one-walled blood vessels, so it will be easy for the solids to move to and from the blood space and the urine space. The tubules then regulate the things that we still need, and the things or the substances or water that we need would go back and eventually exit through the arcuate vein, following the circulation that we mentioned in the previous slide. So let's focus now on the glomerulus, the filtering part of the nephron. If we do an electron microscopy of the glomerulus, it looks something like this. It's like layers upon layers of strainers. So we have the Bowman's capsule, which has a lot of holes, and then eventually you have the cells abutting the blood vessels, which we call the podocytes. But for today, for now, I just like you to appreciate that they're like mesh or they're like salaan. Here, the different blood passes through, so it's understandable why on these different layers we're able to filter the blood into urine very well. Now, in this tubular part, there is concentration that happens, and they're divided into different parts. We have the proximal convoluted tubule, the part of or the segment of the tubule which receives the urine from the glomerular space. It is thick and convoluted or loopy. The next part is we have what we call the loop of Henle. So if we trace the blood from the urine rather from the proximal convoluted tubule, it exits into what we call the loop of Henle. The loop of Henle is the unique part because it has a thick and a thin part. So we have what we call the thick descending loop, the thin descending loop, and then the thick ascending loop. The importance of the thickness of these different parts of the tubule is that the thick ones have a tougher time having water pass through, while the thin ones are very permeable to water. And then after this, we go to the distal convoluted tubule, which is also a flat, horizontal part, which is also loopy. And we can see that the distal convoluted tubule by the juxtaglomerular apparatus is in close coordination with the glomerulus. So the distal tubule and the glomerulus are best friends. Even if they're not next to each other in terms of the flow of the urine, they connect with each other via the juxtaglomerular apparatus. After that, it exits the distal convoluted tubule and it enters what we call the cortical collecting duct. Then eventually the cortical collecting ducts will pull together in the pyramids, and then the urine exits via the renal pelvis and the ureter. So again, you must remember that it is a balance of the items reabsorbed in the blood and also exiting the urine that the kidney regulates everything. Now, what is the renal function? Renal function is fluid regulation. So it balances out our fluid, controls our blood pressure and volume by producing more urine if there's excess fluid and less of it if we are dehydrated. Other than that, it excretes waste by filtering the blood to remove urea, creatinine, and drugs. Urea and creatinine are the building blocks of our muscles, and if we don't need them anymore or we consume excess protein, it exits the kidney. It exits the kidney. And lastly, it also regulates the acid-base balance. So it regulates the pH level of the blood by balancing out our bicarbonate and hydrogen ions. I'd like to focus today on the glomerulus. So the glomerulus, if you think about it, is divided into layers and can be likened to this salaan. We have this blood entering this tube, and then it passes through different layers until ultimately we're able to get the most ideal filtrate that we can, preserving the things that we need and throwing out the things that we don't need. So if we magnify it, they're divided into different layers. So we would have the glomerular tuft, which is like the blood vessels convoluted together. If we take that, so it's the one here. Then if we take it out, then we have the Bowman's space, or because the renal tuft is enveloped by what you call the Bowman's capsule. So the space between them is what you call the Bowman's space, and then the capsule are like the cells which are wrapping around the blood vessels. Now, later on, we'll also show you the different epithelial cells near the blood vessels or the capillaries, which we call the podocytes. But suffice it to say in this picture that they look like strainers as well. So the blood passes through different layers in order for us to preserve what we need and to waste and to excrete out what we don't need. So the filtrate or the substances that exit the glomerulus are much like blood. However, they are protein-free because we save them. There are no cellular elements. Although calcium can easily be passed out as well as fatty acids, calcium and fatty acids are very close to the protein. They bind together. And since protein cannot pass through these strainers because they're very big, calcium and fatty acids are not filtered because they are protein bound. Now, if we stretch out our glomerulus and our afferent and efferent arterioles, we have this. So again, to review for our blood vasculature, we remember that there is blood entering the glomerulus to the afferent or the approaching arteriole. So what happens is that blood enters and then the filtration happens. In the glomerular capillaries, the blood passes through, going into the Bowman's capsule, being transformed from blood into the urine. The glomerular filtration rate is around 125 ml per minute, which is quite fast. But we can't throw out the 125 ml all the time. We need to reabsorb them because our body needs to be efficient in conserving what we need, so the tubule is in charge of doing the reabsorption. So it reabsorbs around 124 ml per minute, causing our urine to be very low in volume. So we just put out what we need in a rate of 1 ml per minute. So the reabsorption happens between the tubule and the peritubular capillaries, and then the blood exits the renal vein containing the things that our body still needs and we can recycle. Think of it as similar to the coffee maker. So what happens is that we have a force pushing the blood into the urine, which is similar to the water pushing out the coffee mini granules through a filter. So what happens here is that we're able to filter out, and then we're able to excrete or put out the smaller things that we don't need anymore. This concept will be helpful in making us understand the glomerular filtration rate. GFR is the volume of plasma filtered through the glomerular capillaries per unit time and is measured by ml per minute. So let's recall that again, it looks like this, the blood going through the salaan. So if we go back to our glomerulus and do a cross-section, it will look something like this. So we'd like to orient you. Again, we have our capillary tuft. So the blood enters to the afferent arteriole, goes into the glomerular capillary tuft, and is filtered through the capillary basement membrane. In the capillary cross-section, we can see that there are a lot of fenestrations, causing a lot of the solute that we don't need to exit. However, there is another layer which makes sure that we save that we need. So this is what we call the epithelial cells. The epithelial cells. This is the cross-section, but this is what it looks like. The epithelial cells, or what we call the podocytes, look like cells that are hugging the capillaries, and they have what we call the foot processes or feet, little feet. These little feet have spaces in between them that we call the slit pores, which are also responsible for filtering out the things that we need and the things that we don't need. Ultimately, the urine exits in the Bowman space and then enters the proximal convoluted tubule or the tubule of the nephron in order for it to be regulated further. Now, in the glomerulus again, this is what it looks like. The important thing for us to be able to produce the filtrate is the filterability. If we remember, the glomerulus has holes, and these holes allow the different solutes to pass through. An important physiologic concept is that filterability is inversely proportional to size. The bigger the substance, the harder it will be to go through the strainer. And also, if we remember, the glomerular basement membrane or the cells are negatively charged, so it would be easier to filter the solutes that are positively charged. So here we have a list of the filterability of the different substances in the glomerular capillaries. So if we look at the different substances along with their molecular weight, we can see that the smaller substances from 18 to 5 molecular weight have a very good filterability of 1, meaning all of them can pass through the glomerulus. However, the bigger substances like the proteins, namely myoglobin and albumin, are quite big, so their filterability decreases. So just to show you a picture, we have here a picture of the different proteins. So we can see that the albumin is quite big. And then as we go along, it becomes like the gold. So these things will not be able to pass through the filter of the glomerulus. So how do we apply this in real life? So again, let's remember the cross-section. We have the epithelial cells or the podocytes, the glomerular basement membrane, and also the endothelial cells, which have the slit pores. So these are like the 3 strainers. So it's supposed to be able to conserve the protein that we need in our body, and none of the protein is supposed to exit because it's too large. However, for some patients, the strainer is destroyed. We can see here what we call the podocyte or the foot process effacement. These strainer-like patterns sticking out are no longer seen and they're already flat. And what we can see here is that the urine would eventually have bubbles, which indicate the presence of the protein in the urine, which is not supposed to happen. So this will cause different problems for the patient, causing loss of urine, maybe loss of protein in the urine, or maybe malnutrition eventually because we lose out the protein that we need. So this is one of the clinical applications of the glomerulus. Now, how are we able to determine the speed by which the filtration happens? We have what we call the determinants of the glomerular filtration rate. So for this formula, we have that Kf, or the filter, or the filterability, or the filtration coefficient, or basically the power of the filter to admit the different solutes. That's what we call Kf, or the filtration coefficient. Then we have a combination of the net filtration pressures. So as we know, the pressures or the water pressure can help us determine the movement from the blood to the urine side. The higher the pressure in the blood side, the more we'll be able to push the filtration from the blood to the urine. Net filtration pressure is then composed of 4 items. We have the PG, or the glomerular hydrostatic pressure, the PB, or the Bowman's capsule hydrostatic pressure, and then the pi G, or the glomerular osmotic pressure, and pi B, or the Bowman's capsule osmotic pressure. This formula is quite difficult for me to understand at first, but it makes me easy to remember via a picture form. So let's go back to our figure. Again, we have our glomerular tuft and our Bowman space. We stretch it out so that it just looks like 2 compartments. So again, we have the blood space and the urine space. So we have the formula on the left side. Now, what I'd like you to remember is that hydrostatic pressure is like a pushing pressure. It can be likened to filling up a balloon with water. When we fill up a balloon with water, it pushes the rubber out, thereby making the balloon bigger. So it's something that happens also here in the glomerulus. In the blood space, you have what we call the glomerular hydrostatic pressure, which is the pushing of the fluid in the capillary. So what happens here is that if there's pushing, the filtration force is driven. Blood is pushed to become the urine. However, what happens is that in the Bowman space, it's also composed of fluid, so it will also push back. But the different part here is that the urine will flow down from the Bowman's capsule into the tubule and eventually in the collecting duct and then the ureter to exit as urine. So there is a continuous downward flow of the urine, causing less pressure or less pushing pressure or less Bowman's hydrostatic pressure in this area. Now it was measured as 60 versus 18. So here that we can see that the net movement will be a hydrostatic pressure going from the blood into the urine space. However, for oncotic pressure, it's like a pulling pressure similar to a sponge. So how I imagine it is that if you have different proteins or different substances, they would be like different sponges. So the different proteins would be present in the blood, but if we remember, the urine will not have any protein. So the glomerular colloid osmotic or pulling or sponge pressure is at 32 millimeters mercury. So even if it pulls back, the net pressure is lower, driving the movement of the fluid from the blood into the urine space. So we remember it's a combination of the hydrostatic or pushing pressure and the oncotic and the pulling pressure. Now, how is this applicable? So in this table, we can see that there are factors that decrease the glomerular filtration rate. So it can be controlled by different aspects of the formula. And I'd like to state it in a real life form. So in the first table, in the first row of the table, it says that a decreased KF or a filtration coefficient can cause decreased infiltration. So how I imagine that is that in patients with kidney disease or diabetes or hypertension or aging, what happens is that the membrane in between the blood going into the urine, instead of becoming a very soft porous filter, becomes like cardboard. So because of that, there is inability of the fluid and the solute to pass through, causing a decrease in filtration. In the second example, we can have what we call the urinary tract obstruction, which happens when we have kidney stones. So if you have family members who have kidney stones, what happens is that the urine that is going out is obstructed. As such, the water pressure here increase. And if you remember, the water pressure is the hydrostatic pressure. So instead of maybe having the low Bowman's hydrostatic pressure, because it's unable to go out, this will stretch much like the balloon, pushing against the blood or the glomerular hydrostatic pressure. So what happens here is that the movement or the GFR will not proceed as efficiently as before. For the third example, sometimes you can have what we call increased plasma proteins or in disease conditions such as multiple myeloma. So the blood in these patients is very viscous and it's like having many sponges or increased oncotic or pulling pressure. In which case, sinisip-sip niya yung water or water is being pulled into the blood space, causing a decrease in the movement of the water from the blood to the urine space or decrease in glomerular filtration rate. Another example are medicines which we call the ACE inhibitor, which is responsible for opening the efferent arteriolar pressure. So here we see it. So what happens here is that when this is opened up, the movement of the blood will be faster or slower. It will be faster. So because it exits more quickly, there will be no time for the blood to be pushed to become urine, and the glomerular filtration rate will decrease. Lastly, we have what we call the norepinephrine, which we studied also in the nervous module. So norepinephrine is also a medication which can make the afferent arteriole smaller. So if the afferent arteriole is smaller or the resistance is larger, what happens is that the blood will not be able to enter as well, and because there is low hydrostatic or pushing pressure of the blood here, the eGFR will be decreased. So this slide generally summarizes how we can apply the glomerular and Bowman's hydrostatic, oncotic pressure, and filtration pressure to explain the different conditions and disease entities which can decrease the glomerular filtration rate. Now, as we have seen in the previous example, the renal blood flow is quite important. If there is decrease in renal blood flow, we would expect the glomerular filtration rate would decrease, causing destruction in the kidney. So there are different systems in the body that regulate the renal blood flow so that it remains constant at arterial pressures of 80 to 200. Meaning that if you have your mean arterial pressures, even if they're quite variable, you can see that the renal blood flow here is quite constant. So in this table below, you would have the urine output depending on the mean arterial pressure. We can see here that if the pressure is increased, indicating a higher fluid in the body, you would have an increased urine output as well. The kidneys would try to compensate in order to take out the fluid. Also, the renal blood flow remains steady in ml per minute despite the differences in glomerular filtration. So the kidney does its best by regulating the afferent and the efferent arteriole in order to make sure that the blood entering the kidney is sufficient to push filtration. But how is the kidney able to tell if it's enough or not? We have what we call the renal auto-regulatory mechanisms. So again, I like to orient you to this picture. We have the glomerulus going into the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and then the cortical collecting duct. However, in real life, the glomerulus, which looks like this, is actually best friends with the distal convoluted tubule. It's not something linear, but they're like really curved with each other. And the glomerulus is in love with the distal convoluted tubule. So they're paired together. So they're paired together by what we call the juxtaglomerular apparatus, which has what we call the macula densa cells. So here in the distal convoluted tubule, if you do a cross section or you cut it and look at the view, we can have what you call the regular tubular cells and the macula densa cells. The macula densa cells are quite special. They detect the presence of sodium concentration in the tubule. So for example, in the glomerulus, we're able to filter out the water and the sodium. The sodium is mainly the measure of the solute concentration. The higher the sodium, the more concentrated the urine, and it means that a lot of filtering is happening. Now, by the time it reaches the distal tubule, magchichismisan sila. It's like the distal tubule has a megaphone which connects with the glomerulus. So what happens is that it regulates the entry of the blood, and if there's too much, it makes the afferent or the approaching arteriole close. But if it's too little sodium, it will tell open pa, kulang pa yung sodium. So generally, the macula densa cells affect the caliber or the resistance in the afferent or approaching arteriole. So autoregulation mechanisms ensure constant blood flow, and it happens by three mechanisms. First, you have the sympathetic nervous system, which regulates the renin system release and the water and salt reabsorption. Other than this, we have the myogenic mechanism, wherein the renal afferent arterioles, they contract if they're too stretched out, and we'll show this in a picture later. And the third, we have the tubuloglomerular feedback, wherein the renal arterioles and the macula densa are best friends and interact with each other. For the sympathetic nervous system, it was discussed previously in your other modules. So I'd like to concentrate on the myogenic mechanism, wherein the renal afferent arterioles contract in response to stretch. So what happens is that if you have increased renal blood flow, then the afferent or the approaching arteriole will stretch out. So it will be much like a rubber band. It will tell the afferent arteriole, the glomerulus will tell the arteriole, hey, I'm being too stretched out. So what happens is the afferent arteriole will regulate and say, okay, and then become smaller. The muscles will contract in order to make the diameter of the afferent arteriole smaller. For tubuloglomerular feedback, what happens is that the renal arterioles interact with the macula densa. So again, if there's too much sodium that enters the distal tubule, the macula densa will talk to the arterioles and will tell the afferent arteriole, hey, too much sodium, so lumiit ka muna, so that not a lot of blood will come, and then the glomerulus will have time to breathe. However, if there's lack of sodium, indicating that there's we need more filtration to happen, then the macula densa will tell the afferent arteriole to open. So here, what happens if it opens is that GFR will increase. So again, it will just regulate each other through these mechanisms. So to review, the macula densa is a collection of specialized epithelial cells in the distal convoluted tubule that detect sodium concentration fluid in the tubule, and it communicates with the afferent arteriole. So key terms, chismosa, megaphone. Si distal, kakausap kay glomerulus. This is what you call the tubuloglomerular feedback. Now, the book outlines it to be the following. So, if you have decreased arterial pressure, then you would have the decreased pushing or the glomerular hydrostatic pressure. The balloon inside this blood space will not be big because there's low fluid. Therefore, the glomerular filtration rate will decrease, causing less sodium or less filtration to go through the tubule. And by the time it reaches the distal tubule in the macula densa cells, it will detect low sodium chloride. So what this does is, I need more sodium. So it secretes renin and angiotensin, causing an increase in the arteriolar resistance, or it will make the efferent or the exiting arteriole smaller. When it's smaller, the blood remains there and the GFR is increased. So other than this, what it does is also to try to open up the afferent arteriole if there's a decrease in GFR. So if the afferent arteriole is open, more blood will come through and the GFR will increase. Now we've completed the discussion in the filtering part of the nephron, which we call the glomerulus, and I'd like to summarize a bit on tubule reabsorption and secretion of electrolytes. If we recall, the glomerulus is the one that produces the urine, and the tubules would be the one to regulate its concentration and content of solute for us to save what we need and to secrete what we don't need. So at the end of this portion of the lecture, we hope that we'll be able to review the different transport mechanisms in the renal tubule, discuss the renal handling and reabsorption of the different solutes, and enrich our knowledge about the tubular cell. Now, again, we recall that the nephron is the functional unit of the kidney. We remember this picture, so we've already discussed the glomerulus, and now we'll go to the tubule. The tubular segments again are the proximal convoluted tubule, which comes from the glomerulus. We have the loop of Henle, which has the thick descending loop, the thin descending loop, and the thick ascending loop. The distal convoluted tubule, which contains the juxtaglomerular apparatus and the macula densa. Then eventually the cortical collecting duct, which is ultimately responsible for concentration and water reabsorption if needed in the urine. So we remember that it's a collection. The tubule is a collection of cells that gives back to us via tubular reabsorption the things that we still need, and exits into the urine the things that we don't need. So urinary excretion is a collection of these three parameters: glomerular filtration, tubular reabsorption, and tubular secretion. So this is what it looks like stretched out, and this mnemonic was quite helpful for me in remembering the renal tubular functions. So every waterfall raises sodium in exchange for potassium to make another waterfall. So every in the proximal tubule means that generally it reabsorbs everything, or the organic anions, the water, and also the electrolytes. Waterfall means that generally we try to reabsorb the water so that the sodium will be raised by the time it goes up. Potassium regulation happens in the distal convoluted tubule, and water and also potassium regulation can happen in the cortical collecting duct. So first, you need to remember that again, glomerular filtration rate, filtration is composed of glomerular filtration rate times the plasma concentration. So what's important to remember here is the glomerulus is generally non-discriminating. It just passes through based on the concentration gradient from an area of a higher to a lower concentration. So because we have that in the glomerulus, we have in the blood a high concentration of all these substances, the amount filtered is quite high. However, our body would be kind of wasteful if we throw away the glucose, bicarbonate, sodium chloride, potassium. So the tubule really works hard to reabsorb them. If we notice in the first panel, the glucose that is filtered is 180, but the amount that is reabsorbed is 180 milligram per deciliter. So it's very efficient because even if the glomerulus throws it out, the tubules reabsorb them because we need them for energy. And we tend to reabsorb 100% of the glucose that is filtered through the glomerulus if in a normal state. We notice here that for the substances that our body needs, the percentage of filtered load that is reabsorbed is close to 100%. However, for the waste products, namely like urea and creatinine, which are protein degradation waste products, we can notice here that they are excreted out. Around 50% of the urea is reabsorbed, 50% is excreted. But we notice here that for the creatinine, none of it is reabsorbed because we have a wealth of that in our body. So a lot of it is excreted. Now, the tubule is a highly selective organ. It can choose what it throws out and what it keeps in, unlike the glomerulus. So generally, the tubule is quite a difficult thing to imagine. So I'd like to orient us in terms of the tubular cells. What I imagine is that the tubular cell is like a hotel, and there are two roads. The road in front, the main road or the urine road, and the road at the back or the blood road. Generally, in the blood, you would want to save back what we need, but in the urine road, it's a way out to throw out the things that we don't need. So the goal mainly is that for reabsorption from the main road, we need to go to the back road. And there are two ways to do that. We can go through the hotel or we can go through the alleyway in between each hotel. One hotel is like one tubular cell. So this is the way that I easily remember it. Now, if we recall, we have our best friend, the sodium and the potassium ATPase pump, which we met before. The sodium and the potassium ATPase pump are like revolving doors. It is usually located at the back of the hotel, or if we orient ourselves, it's in the basolateral side of the tubular cell. So we recall that the sodium potassium ATPase pump exchanges 3 sodium for 2 potassium in an energy driven manner. So what happens is, the way I remember it is, it's like a revolving door. For every 3 sodium friends who are exiting the hotel, there are 2 potassium friends entering the hotel. So the significance again of the sodium potassium ATPase pump is that it helps you orient yourselves. More often than not, it's located in the basolateral side of the tubular cell, and it's necessary and a driving force for the movement of the other solids which will be reabsorbed. Now, the different routes of transfer from the urine to the blood side can happen through different channels. In the apical side, or in the road side or urinary side, we can have what we call the antiporters, which are also like revolving doors, wherein there can be one electrolyte or one substance going in exchange for the other. Normally, it's sodium. Normally, sodium would go in and then another substance would go out. So we call this the exchangers or the revolving doors. But we can also have what we call the co-transporters. Instead of being like revolving doors, they're like the normal doors, wherein two substances enter together. Normally, one is usually sodium. So, for example, if the sodium enters with glucose, then we would have the sodium glucose co-transporter. So, if they pass through all these doors, the co-transporter or the regular doors, the antiporter or exchanger, which are the revolving doors, they need to exit out. And the manner by which the substances transfer here are what we call transcellular route. However, the other route that substances can enter the blood from the urine side would be what we call the paracellular route, or the route in between the tubular cells or the hotels. It's like the alleys in between the hotels. So this is what we call the paracellular route. So for the important concept, so we need to remember that, no? We need to remember that because things will be getting confusing. But the main important thing for you is, number one, to orient yourself. Which one is the blood side? Which one is the urine side? Where is the sodium potassium ATPase pump? And what is the important transporter that we have in the apical side? So those are the 3 steps. So for the transport of the fluids in the tubules, this is how it really looks like. So again, remember to orient yourself. You have the apical side or the urine side and the basal side or the blood side. Then generally, if it's for reabsorption, we would have that from the urine side, the cells would be moving back to the blood either through the tubular cell or the transcellular route or through the paracellular route or in between each cell. So if they're reabsorbed, it goes back to the blood, but if it doesn't go in, it's excreted in the urine. So for the modes of transport, let us review. We have the primary active transport wherein we have the sodium potassium ATPase pump. We can have hydrogen ATPase, hydrogen going against the concentration gradient with energy. We can have hydrogen potassium and calcium ATPase as some examples. For the secondary active transport, we have the sodium potassium ATPase pump, wherein then the energy that we need for the other movements to occur is driven by this basal pump. Then also, it's the first line of the redistribution between the intracellular and extracellular fluid compartments in order to maintain tight serum electrolyte levels. So here we have the sodium potassium ATPase pump moving the sodium from the apex back into the blood. Next, we can have the water which passes through osmosis either through transcellular or paracellular route. Then we have facilitated diffusion. So we can have the substances moving from an area of higher concentration to lower concentration, for example, glucose, via a transcellular or a paracellular route. And lastly, we can have the movement of the solutes when they are dragged in with water by hydrostatic and oncotic forces, which we call the solvent drag. Now, another important concept is what we call the transport maximum. So what happens is that if there are channels that are moving the substances from the urine to the blood, there's a maximum amount that we can put in, and this is what we call the transport maximum. Imagine that I threw you some money. If the money was just thrown at a rate where you could get it and there's just very few bills, of course you can get them all with both your hands. However, if there's a millionaire who comes along and throws in a lot of bills, even if you had wanted to, you cannot pick them all up because of the limited amount of hands that you had. So this is similar to what we call the transport maximum. So transport maximum, here we have the different tubular cells and we have the urine space. So in this example, 5 solutes can be the ones that be reabsorbed per minute because there are only 5 transporters that are present. So transport maximum is reached when the carriers are saturated. Different items in the blood have different transport maximum, and the most popular one that is studied is glucose. The transport maximum of glucose in the blood is 375 milligram per minute, and the filtered load is usually 125 milligram per minute. So here in this chart, we're able to see the transport maximum chart. In the vertical axis, we have the glucose filtered load, reabsorption and excretion in milligram per minute, and in the horizontal axis, we have the plasma glucose concentration. What we can notice here is that if the plasma glucose concentration increases, there will be a limit into the amount. If the glucose concentration increases and is filtered out, there will be a maximum amount that can be reabsorbed, and this is what we call the transport maximum. It happens when it's saturated, so at the level of 375 milligram per minute, we cannot get any more money or any more glucose even if we had wanted to. As such, the glucose will be thrown out in the urine. If we go above the threshold, then eventually the urine from this part wherein there is no glucose because we're able to catch it all will be excreted, and there will be what we call glucosuria or glucose in the urine. So in an example, if for example, our patient is diabetic, the glomerulus filters out a lot of the glucose, we would want to reabsorb the glucose because it's useful. But there's a limit to that we can reabsorb. So more glucose will be thrown out because saturation is already reached. Now let's go finally to the generalities of the different tubular segments. So generally, form follows function, and the thick segments are relatively impermeable to water. So by baseline, normally, the thick parts of the loop of Henle, as well as the distal convoluted tubule and the collecting tubule are impermeable to water. What is permeable to water would be the thin part of the loop of Henle. So again, let's recall the mnemonic. Every waterfall raises sodium in exchange for potassium to make another waterfall. Now let's begin with the proximal convoluted tubule, or the EVRI. So the proximal convoluted tubule reabsorbs glucose, amino acids, and other solutes. When in doubt and when you're asked regarding the area that reabsorbs everything, because always remember, it's the highest concentration because it comes directly from the glomerulus. The glomerulus doesn't really think about it. It just spills out what it does from an area of higher to lower concentration. If you remember, the hydrostatic pressure will push everything out. So the proximal convoluted tubule is trying busily to catch everything. So it reabsorbs sodium, chloride, bicarbonate, potassium, water, glucose, and amino acids. And it excretes those things that we don't need anymore. So these are the bile salts, oxalate, urate, and catecholamines. The reabsorption happens in terms of sodium, 65% of it is reabsorbed inside the proximal tubule. Now, for the waterfall part, raises sodium, or the loop of Henle, we have the thick and the thin parts. So in the thin parts, what happens is that there is a diffusion of the water. 20% of water is reabsorbed in the thin descending loop of Henle. However, so what happens here is that since the water is reabsorbed, what would happen is that the concentration of the solids would increase because they're not able to pass out. So when it arrives at the thick ascending loop of Henle, what happens is that it's thick, so it would reabsorb in this place the solutes through channels. So what are reabsorbed are the sodium, chloride, potassium, calcium, bicarbonate, and magnesium in exchange for the hydrogen ion. So when you magnify or look at the tubular cells, it would look like this. So always remember to orient yourself. So where is the blood side or the basal side? We look at the one near the sodium-potassium ATPase pump. And then we look at the urine side or the apical side where the other doors or the other channels are present. If you would want to reabsorb things, the movement will be from the urine side to the blood side. So the most important door or co-transporter is what we call the sodium to chloride potassium co-transporter. This is like an opening door wherein 1, 2, 3, 4 na magkakabarkada would enter. So we have the sodium, the 2 chloride ions, and the potassium will enter all together. Now, once they enter the hotel, they need a way to be able to exit going into the blood. So the sodium will exit through the sodium-potassium ATPase pump. The potassium would exit through potassium channels. So even if here in the ATPase pump, there is a potassium that goes in and potassium that goes in. So ang dami na nilang potassium na magkakabarkada. Because of the higher concentration, it will move out through potassium channels through the basolateral side into the blood. Then the chloride will enter also through the sodium to chloride potassium co-transporter, then exit through a chloride channel. Now, sometimes if we give medicines like diuretics, this can be blocked. So these all will not enter, and the water coming out from the urine will push this down, causing diuresis or diu. Two substances will be pulled out, namely water and sodium, because where sodium goes, water follows. So next, we go to the distal tubule, which is in exchange for potassium. So again, here, the important concepts to remember are the presence of the macula densa, which communicates with the renal vasculature. If there's too much sodium, it will tell the afferent arteriole, hey, wait lang, mag-close ka. But also, since it's thick, it's a diluting segment, it's impermeable to water. So in the early distal tubule, it can reabsorb the sodium, chloride, calcium, and magnesium. And in the late distal tubule, it can still reabsorb them in exchange for potassium. But sometimes there are water channels that are present because they are sensitive to aldosterone. I'll discuss that later. So for the purposes of today's discussion, we reabsorb sodium, chloride, calcium, and magnesium through the distal tubule, and it's impermeable to water. So generally, this is what it looks like. You have the sodium-potassium ATPase pump on the basolateral side near the blood, and then in the apical side, in this particular hotel, we have this special door which we call the sodium chloride co-transporter. The sodium and the chloride are magkakabarkada who enter the same door, and sodium enters the cell and exits into the blood via the sodium-potassium ATPase pump. The chloride enters and exits via chloride channels. This can be blocked by a thiazide diuretic, so the thiazides will close the door, causing the loss of the sodium and the chloride into the urine when the water pushes it out. So it's also sensitive to principal cells or aldosterone, which we'll be discussing in greater detail in the cortical collecting duct. Now, for the last part of the tubule, we have the cortical collecting duct, and it makes another waterfall. So intuitively, we think that it's not permeable to water because it's thick, but it's sensitive to the aldosterone. So the medullary collecting duct is sensitive to the aldosterone and also to the vasopressin or the antidiuretic hormone. So what the antidiuretic hormone does, it's a captain. So it's a captain that calls in the different channels that are present. Normally, the cortical collecting duct is impermeable to water, so it's thick and it can't pass through. But if we have if we have too little fluids in the body, we need antidiuresis by vasopressin. Papabawasan yung kung kulang yung tubig natin sa katawan. So since it's not able to reabsorb normally, the vasopressin will call different aquaporins, which are different channels, and they will be created. So these aquaporins will then intersperse themselves into the channels in between the urine and the blood, and here the water will be able to pass through. So it's like the vasopressin will call on the construction of different gates or channels called the aquaporin. So even if it's thick, the aquaporin will be here, and then the water will be able to pass through. If we need more diuresis to happen, antidiuretic hormone action will be decreased and the gates will not be there. So today I've introduced a bit about the glomerulus and the tubule. I hope that I was also able to define the key components of the renal system, explain the function of the nephron, and understand a bit about the regulation of blood pressure. And I hope that even if it's an overview, in the future we'll be able to use renal physiology in our dental practice. Thank you very much. And if you have more questions, you can just email me or contact me in Canvas or through our liaison officer. And there are other videos and materials in the Canvas module. I invite you to have a look at them for better understanding. Thank you very much and have a great day.